Hey, first of all, thank you very much to the organizing committee for inviting me. I was in Tashkent last May. Unfortunately, I could not come back this October, but I really appreciated the Uzbekistan culture and also people. So I will for sure come back probably next year, but this time I will only give an online lecture, so please forgive me. So first of all, I would like to tell you who I am and where I come from. So I am an associate professor of cardiology at the University of Padua, and Padua is here close to Venice. In fact, the Padua Medical School is indeed the School of Medicine of Venice. And Padua is very old university. It was established more than 800 years ago. And many important scientists study in Padua, such as Galileo Galilei, Vesalio, Morgagni. And today, if you come to Padua, you will be able to visit the famous ancient anatomical theater where autopsies were performed 500 years ago and many fundamental discoveries were made, particularly in the cardiovascular science field. In Padua, I act as a sports cardiology, and sports cardiology has many fields of interest, including the study of the morphofunctional cardiovascular system adaptation in response to exercise, differential diagnosis between athletes' heart and cardiovascular disease, pre-participation screening of the athlete, advice on sports participation of athletes with cardiovascular problems, exercise prescription in patients with cardiovascular disease, and also implementation of resuscitation programs in the sport fields. But what is the topic of my presentation is the first point. So the morphofunctional cardiovascular adaptation to exercise. In other words, is it always beneficial or sometimes can be dangerous? Because you know for sure that the health of the human body depends on exercise. Exercise, in fact, regular exercise, in fact, improves cardiovascular system, musculoskeletal well-being, reduce the risk of cancer, etc. But talking about the heart, there are some theories according to which sedentary individuals are at increased risk of cardiovascular diseases, whereas a healthy lifestyle, including regular exercise, is beneficial and decreases the risk. However, if you do too much exercise for too many hours and with too much intensity, maybe your cardiovascular system may be endangered. So what are the evidence? Well, there are a certain number of topics that can be addressed in this field, either acute effects and chronic effects. However, I will focus only on 4 important topics. And the first one is the sinus bradycardia and atrioventricular block. So everybody knows that the electrocardiogram of an athlete is different from that of sedentary individuals. Athletes usually have a lower heart rate, can be as low as 30 beats per minute, and also can show delayed atrioventricular conduction. In other words, the electrical impulse travels from the atrium to the ventricles with a slower pace. But is it dangerous or is it normal? Well, indeed, in theory, this has always been considered as a benign effect of parasympathetic activity. You know, athletes have an increased vagal tone, and as a result of this increased vagal tone, they can experience sinus bradycardia, and this is the theory. However, it's also common experience that former athletes, those that ceased their athletic career and they are not athletes anymore, remain bradycardic after several years. So this sinus bradycardia of athletes does not seems to be completely reversible with the training, and this is not compatible with just an increased vagal tone, because, as you know, increased vagal tone, if you do train, decreases. So what is the mechanism? Well, yes, there is an increased vagal tone, but what has been discovered in the last few years is that if you train for a long period, there is a remodeling of the ion channels, so the channels that are responsible for the electrical activity of the heart changes in number because of a response to exercise. So it's not just the neurosympathetic activity that modifies, but it's a more profound effect on the ion channels of the myocyte cells. The question is it reversible, completely reversible, or not? And if it's not completely reversible, can this modification lead to pathological bradycardia, maybe leading to a pacemaker implantation in former athletes? So we did a study, in a couple of studies in Padua. The most important is that we reviewed how our population of patients with a pacemaker with no heart disease. So those that received a pacemaker just for a primary bradycardia and without the other diseases. And we found that among these 73 patients that received a pacemaker before the age of 70-year-old, 18 were former professional athletes, 20 were control groups, and the others were neither athletes nor with idiopathic dysfunction. And we found that athletes received a pacemaker on average 10 years before non-athletes. And there is a trend towards a correlation between the training volumes in their life and the probability of receiving a pacemaker earlier in their lifetime. So today we have quite a different perspective about bradycardia in athletes. We think that in a majority of cases this is a benign phenomenon, but in some cases probably it is not. So if you train and exercise for a long period in your life, then your heart rate will, of course, become lower, but maybe will stay lower during your lifetime, potentially leading to the need for a pacemaker. This is, of course, preliminary observation, but this is something that we are studying. And the reason is probably relates not only to increased vagal tone, but also to downregulation of ion channel genes, and possible also catecholamines oxidative damage due to exercise. Second topic, coronary artery disease. So everybody knows that doing exercise prevents myocardial infarction. However, evidence suggests that long-term intensive physical exercise may promote calcifications of the coronary artery. So again, a U-shaped relationship. If you do not do exercise, then your coronary arteries will get sick. If you do regular exercise, that's the best. But intense and prolonged endurance exercise may, in theory, favor coronary calcifications. And there are quite a large number of studies showing that athletes have a higher prevalence of coronary calcifications compared to normal individuals. Calcifications of the coronary arteries does not necessarily mean myocardial infarction, but it's a risk factor. And so now what we are studying is whether those increased calcifications of the coronary artery can be considered a physiological phenomenon without clinical relevance, or if long-term endurance exercise may paradoxically predispose to myocardial ischemia. Another topic is the post-troponin exercise release. You know, if you do troponin, I mean, maybe nobody, not all of you knows it, but troponin is a blood test that we perform in the suspicion of acute myocardial infarction. Troponin is released from the myocyte cells when the myocytes are damaged, usually by an ischemic event, like myocardial infarction, but also after myocarditis. However, if you check troponin levels after a marathon or another endurance exercise, there is a great chance that you will find the troponin levels above normal. So, what is the reason? Is this, a sign that exercise has damaged the heart? Or are there other explanations? So, we know that the probability of finding an abnormal troponin level in an athlete correlates with exercise duration and exercise intensity. And very interestingly, the curve of the troponin release has this shape, which is very similar to that you can observe during myocardial infarction. However, levels usually are not very high. If you have a true myocardial infarction, you can observe levels as high as 1,000 times the normal levels. Here we are talking about 3-5 times the normal levels on average. So there is a small troponin release. However, in theory, if every time you exercise, you make a damage to your heart a little bit, then after a long time, in theory, your heart can get sick. Today, we don't know, honestly speaking, if this troponin release is the sign of necrosis damage, if it's apoptosis, or if just hallmark of a cardiomyocyte turnover, which can be also physiological. So we don't know if this troponin release is pathological or not. But in theory, there might be a possibility that this troponin release after exercise is a sign of myocardial stress that can be on a long term potentially pathological. Today, we think that in most cases can be considered a physiological phenomenon, but we don't know. And this lead to the final topic, which is the non-ischemic fibrosis, which is the topic that I have personally studied for a long time, and I find it very interesting. Because, you know, we are observing an increasing number of athletes like this professional soccer player, who suffer cardiac arrest during exercise. I'm talking, for example, about Christian Eriksen, the famous soccer player of Denmark that collapsed during the opening game of the 2021 European Championships of soccer, or other cases. And after those athletes are resuscitated, we perform an MRI, cardiac magnetic resonance, to understand the reason why this event happened. And what we find is this. So let me show you this figure. This figure shows a post-contrast CMR image. So the images are acquired after the injection of gadolinium, which is a contrast agent, which deposits in the zones where there is an increased interstitial tissue. In other words, fibrosis. So the healthy heart is black, but where you find this increased signal here in the wall, this means that there is a fibrosis. And because the fibrosis involves the outer layer of the heart, the origin is not ischemic, because if this is an infarction, then the inner layer of the heart is involved. If the outer layer of the heart this means that the damage is not ischemic. So the problem is that it's very difficult to detect these scars with echo only, because these scars usually do not modify the systolic function of the heart. You need an MRI, which of course is not available in every place. But we now know what are the red flags, what are the risk factors for this scar, in particularly apparently unexplained arrhythmic events, apparently unexplained electrocardiogram abnormalities, or complex ventricular arrhythmias. And this scar is a very common finding at cardiac magnetic resonance. But today, the question is, what is the cause of this scar? It's not a myocardial infarction, so what it is? Well, the truth is that this scar can be found in patients with acute myocarditis. Okay, so if you have an acute infection of the heart, you can develop this kind of scar. However, in our athletes, we don't have usually any history of acute myocarditis, so no chest pain or dyspnea during an infective illness. And another important fact is that if you compare athletes with sedentary individuals, the probability of finding a scar in an athlete is higher than that of sedentary individuals. And what is the reason? So a possibility is that this scar is indeed caused by a viral myocarditis that the athlete was not aware of. So maybe he had a flu or a gastroenteritis, and the virus damaged the heart without the athlete knowing it. And from this point of view, we know that particularly endurance exercise reduce the immune response to viruses, so athletes are at higher risk of viral infection. And for this reason, there is a chance that athletes are more prone to myocarditis and post-myocarditis scars than sedentary individuals. But another interesting possibility is that the physical stress of exercise directly damages the heart, and in some predisposed athletes causes the scar. So we still don't know. Those that I show you today are all areas of uncertainties and all field of research in the future. So in summary, after intense and prolonged exercise, changes in the electrocardiogram, right ventricular dysfunction, elevated troponin levels can be observed, usually with complete recovery within a few days. But we don't know if this repeated repeated stress to the heart can be dangerous in the long term. We know that in veteran athletes with long careers, a higher incidence of bradycardia and atrioventricular block, atrial fibrillation, myocardial fibrosis, and coronary calcification has been demonstrated. However, the good fact is that these athletes, these former athletes, usually have a very long life. They don't die for cardiovascular diseases. So whether this increased prevalence of certain heart disease translates into a bad prognosis, so it remains to be established. It is likely that in the majority of cases, sport practice, even at intense level, provides a health benefit. Maybe in a minority of cases, it may lead to adverse effects. At the end of the day, as Paracelso used to say, omnia venenum sunt, nec sine venenum quiquam existit, dosis sola facit, ut venenum non sit. I know that you probably don't know Latin, which is the ancient Italian language, so I will translate it for you. All things are poison, and nothing is without poison. Only the dose make the thing poison or not. And it's possible that this is true also for exercise. So again, thank you very much for your kind invitation. I hope I will see you in person next time.